Good afternoon, everyone. I'm Lisa Silverman, and I'm here to facilitate today's webinar on mental health parity matters, the role of accreditation in maintaining compliance. We hope you're here today to join us to learn more about URAC's mental health parity accreditation program and really the importance of parity compliance in the year 2021. It's important things have changed over the past year or so, and we've got some great subject matter experts here to talk to you about that. We've got our speakers here. They're going to wave and say hello. Deanna Hardin, our business development executive under this portfolio for us here. We have Robin Adams, who's our vice president for strategy and product development. She just chatted in the chat box. We have Kevin Malone. Kevin works on our mental health parity accreditation programs. He is the guy with the subject matter expert on mental health parity. He's a senior counsel at Epstein, Becker, and Green. And we have Roger Cathal, who is a manager and health consultant. Roger is kind of the person who knows all things medicine, how mental health and behavioral health tie in together. He's also a member of the URAC board of directors. So he's here to share a little bit about why he believes in URAC and what are the benefits of accreditation. So welcome. Deanna, the floor is yours to tell us a little bit more about URAC.
Thanks, Lisa. Good afternoon, everyone. I am Deanna Hardin. I'm really excited to be the initiative lead for URAC's Mental Health Parity Compliance Program and Health Plan Accreditation. I'm here today to tell you just a little bit about who we are and why we believe in accreditation. As you can see on your screen, URAC is more than 30 years old, having just celebrated our 30th anniversary. We are an independent accreditor and we do not provide consulting services. We provide services and support to our clients, including dedicated client relations managers to help guide you through the accreditation process. And our programs are developed by leading healthcare industry experts, and we work in collaboration with those like Kevin Malone, who you'll hear from in a moment, to help craft practical standards that drive improvement through the process of accreditation. Our clients have consistently told us they value URAC accreditation or certifications for some of the reasons you see on your screen. The industry experts with whom we work help drive the rigor and innovative process that introduce our program standards. For that reason, earning a URAC certification or accreditation seal is something you can be proud of and celebrate. URAC offers a wide variety of programs for mental health parity compliance and health plan accreditation. It's my role to help you figure out which program is right for you. And I'm really excited as I saw some people logging in that I've had conversations with you all on the side prior to the webinar. So I'm excited to see you guys here.
And Deanna, I think at the end of the webinar, we'll hear from Roger, who is really, it's always wonderful when our board and our clients can speak to us. So he's going to talk about some of what you saw on slide 2 in there. Robin, I'm going to ask you to come on and set the stage for what's happening in mental health parity at the moment.
Thank you, Lisa. I'm happy to be here. Welcome, everybody. Happy to set the stage. And I can say, as most of you know, there is a lot happening in mental health parity and the continuation of federal statutes. So I thought I could start, next slide, just setting the stage and some of the timeline regarding the federal statutes. I think most of you know about 25 years ago, the Mental Health Parity Act was enacted and signed into law. It went into effect actually September of 1996, so we're almost coming up on that quarter of century. And this law requires annual as well as lifetime dollar limits on mental health benefits to be no less than any such dollar limits for medical and surgical benefits offered by a group health plan, health insurance issuer offering coverage in connection with a group health plan. Prior to the Mental Health Parity Act, it was interesting to note insurers were not required to cover mental health care, so access to treatment was limited. So this really underscored a really important milestone for mental health parity. The Mental Health Parity Act was then largely superseded in October of 2008 by the Mental Health Parity and Addiction Equity Act. I will be referring to that as MAPIA going forward, since that's a mouthful. It was passed and signed into law by George W. Bush in 2008. And really the intent of that and the purpose of MAPIA was to fill in the loopholes that were left by the Mental Health Parity Act. So again, you see this continuation and this incremental requirement through each of these acts and laws that I'll talk a little bit about. And similar to the Mental Health Parity Act, MAPIA requires parity in terms of the total annual benefit dollar limits, as well as the aggregate lifetime benefits. Following the MAPIA Act, we've got the PPACA, Patient Protection and Affordable Care Act, which again extended the reach of MAPIA provisions to many health insurance plans outside previous scope. So specifically, the mental health and substance use disorder services, including behavioral health treatment, think psychotherapy, think counseling, were identified as one of the 10 essential health benefits within the PPACA. And then most recently in 2020, the Omnibus Spending Act was enacted. And under this act, sponsored group health plans must evaluate their compliance with the federal MAPIA to ensure that there are equal coverage limits for mental health substance use benefits and the medical surgical benefits according to the Consolidated Appropriations Act. And again, this went into effect in December 27th of 2020. So again, very recent. And as most of you know, it continued to tighten the enforcement requirements for MAPIA. Next slide, please. So in terms of defining and applying parity, at its core, MAPIA is fundamentally a consumer protection and discrimination statute. MAPIA, from what I've heard and learned from Kevin, has more similarities to the Civil Rights Act and the Americans with Disabilities Act is more in compliance with those, than to most forms of managed care and insurance regulations. Specifically, I'm going to talk about the coverage not required. It's important to note that MAPIA does not explicitly require insurance plans offer benefits for mental health and substance use. However, if they choose to offer both the medical and surgical benefits as well as mental health benefits, they've got to be in compliance and equal according to parity. This includes out-of-network benefits. So again, if a plan chooses to offer both benefits, MAPIA mandates that insurers define and make available specific criteria for medical necessity when it comes to mental health and substance use disorder benefits. And it also requires that insurers provide information and reasons in the event that reimbursement or payment for treatment is denied. In terms of who it's for, very clearly, MAPIA only applies to insurance plans for public and private sector employers with over 50 employees and health insurance issuers who sell coverage to employers with more than 50 employees. Next slide, please. So again, it is an evolving landscape, and the federal statutes that I just noted in the prior slide with stricter enforcement requirements have led to increasing number of parity violations. And in fact, what we do is we continue to track the parity violations levied on national carriers, the most recent of which occurred just last week.
Robin, thanks so much for setting the stage. It's a good lead in to Kevin. And I think, I'm going to go back one slide and just point out some of these signs are pretty hefty up there. We see 2 million, but that's one of the lowest we see, and they continue to happen. This one we just came out on August 12th was Thursday. So it came out of settlement and news then. And I think, Kevin, you'll probably be able to speak to some of these a little bit more, but just this is very real. We're seeing this on a regular basis, and it's going to get pricey. So
that's what we're seeing, Lisa.
And with that, Kevin, I'm going to turn the floor over to you. You're going to talk about what is the onus on health plans.
Sure. Yeah. Thank you, Lisa, and thank you, Robin. So just building really on what Robin was sharing, the Parity Act, as Robin mentioned, is still an anti-discrimination law, and so it does have a totally different set of obligations for health plans with regards to the compliance with the law than you would generally see with things like utilization review laws or state insurance laws or even third-party administrator laws that impact the provision of managed care or other provisions even in ERISA. And that's because parity really requires the application of this general anti-discrimination protection through a series of complex tests to almost everything that managed care companies do. And I think the oversight and enforcement with regards to parity, as you just saw from the slide that Lisa and Robin were talking about before, has continued to increase. And particularly some of the changes that were made by the Consolidated Appropriations Act in late 2020 now effectively require issuers and administrators and employers to be prepared to prove that they are not being discriminatory on request with only 10 days advance notice from the department. And that is really an unusual posture for for things related to discriminatory practices. Those other laws like the Civil Rights laws and the Americans with Disabilities Act, there's a sort of a litigation process that is pursued before and the plaintiff has to prove that discrimination has occurred. Whereas for parity now, the regulators are in a position where there's a presumption of discrimination unless health plans are in a position to prove affirmatively that everything that they do that is subject to parity is being done in a way that's not discriminatory. And so I think that change has not been that sort of posture about sort of effectively guilty until proven innocent has not been the case for the entire time since 2008 when MAPIA was passed. But it has become the case certainly since last December when the statute was amended. Next slide. So to talk a little bit in more detail about the way regulatory oversight works for parity, and it's really as fragmented as our healthcare delivery system is itself. The requirements of parity, as Robin mentioned, apply across all sorts of different kinds of markets, from self-funded group health plans, fully insured commercial products, plans on the exchange, and Medicaid managed care. It really applies the way that I suggest. Instead of saying what it does apply to, it's easier to say what it doesn't apply to. Parity does not apply to Medicare or Medicare Advantage, to PACE, or to traditional Medicaid fee-for-service administered by states. But otherwise, it applies to every other form of commercial managed care programs. And because it's being applied by all these different in all these different markets, the regulatory authority is also quite fragmented. So you have the Department of Labor at the federal level. You also have CMS and CSIO involved in marketplace oversight. You also have CMS doing state oversight with regards to Medicaid. And then at the state level, you have attorneys general and insurance departments also doing direct oversight. And for example, the settlement that was announced last week with United Healthcare involved private plaintiffs, a class action under ERISA, the New York Attorney General bringing suit under both the MAPIA itself and the parallel state law, and the Department of Labor, all sort of wrapped up into one. That's honestly like a perfect picture of what parity oversight looks like, is that you have both, in the ERISA market, you have private beneficiaries bringing suits, and then you also have attorneys general, departments of insurance, and Department of Labor all going after similar entities, all on similar arguments, all under parity. And so the volume of that litigation has continued to increase, and there are now substantially more onerous oversight requirements from 2020 of last year, of December of 2020. Next slide. And so to speak a little bit more practically about what the compliance risks are here and what these regulators and private parties are seeking and what insurance companies need to do with regards to reducing their risk, it really comes down to building a new compliance program at the enterprise level focused on parity. And that really is what URAC's accreditation is intended to assess. It's not, URAC's accreditation is really trying to get to organizational capacity to maintain compliance over time. It's not a point in time audit. It's not an assessment or statement about legal compliance at any given time, because URAC isn't one of those regulatory authorities I mentioned before. But the fact is to systematically reduce enterprise risk from all of these different regulatory authorities, it does require an organizational approach. And documentation is at the heart of parity compliance. A lot of the plans that are getting dinged for parity compliance issues by departments of insurance and by the Department of Labor has to do with inadequate documentation that the activities that are subject to parity pass the parity tests. And so those are, because parity applies to almost everything the managed care companies do that directly or indirectly impacts beneficiary access to care. The documentation requires detailed discussion of why certain things are being done, like prior authorization, concurrent review, but also like the out-of-network reimbursement methodology, the in-network reimbursement methodology. Plan developed network adequacy criteria, medical necessity criteria, retrospective review, all of those things that have an impact directly or indirectly on beneficiary access to care. Those things are subject to parity, and plans have to have ready at all times a current demonstration and analysis of all of the 5 steps to show that that activity meets parity's tests. And so what you see plans really working on right now is going through the process of developing new policies, new procedures to be able to prove, if challenged, that everything they're doing passes those parity tests. And there are certain circumstances where there are per se parity violations. They're becoming less and less common. A per se parity violation would be a situation where a management technique like outlier review or prior authorization is being applied only to mental health benefits or substance use disorder benefits. This comes up most frequently in things related to exclusions. Like there's a blanket coverage exclusion for a mental health service or a substance use disorder treatment service, and that type of exclusion is simply not used on any medical surgical services. You can see why that would be a per se parity violation, because you can't do something only on mental health or substance use disorder services as an activity, because then you'll be comparing your use of something against nothing. And so the regulators are going to say 10 times out of 10 that that's a per se parity violation. But most of the parity violations that are coming up now have to do with things that you may have seen in the settlements announced last week, which have to do with a management technique, outlier review, and reductions on out-of-network reimbursement for mid-level providers. That those sorts of techniques, the reduction in reimbursement for mid-levels and the performance of outlier review, that activity was done to almost all mental health or substance use disorder mid-levels or outpatient mental health services. But conversely, those activities, the reductions and the outlier review, was done very rarely, if ever, on medical surgical services. And the Department of Labor and the New York Attorney General really felt that that activity, that wide disparity in the frequency and intensity of the use, constituted a parity violation. And so that's definitely something that that issuers need to be in a position to prove that at any given time they're engaging in those activities in a comparable ratio of benefits on either side. And that's something that both URAC's Parity Manager and Parity Accreditation program help validate and help ensure that accredited entities are doing that. So there's a lot to contemplate here, and just to sort of wrap up and turn things back over to Robin. I just want to emphasize that parity's requirements are broad and qualitative and quantitative and impact almost every aspect of managed care operations, and that the trends in regulatory enforcement are requiring really a sort of an overall shift in the way compliance is managed at the enterprise level. And URAC's accreditation and Parity Manager products are really designed to help plans go through that process, to change their internal operations, to change their internal culture, to reduce this risk in a systematic way. So with that, I'll turn things back over to Robin.
Kevin, I'm not quite ready to turn it. back over to Robin. Yeah, because there's a question here. And it's asking, is there a safe harbor protection for parity if an organization is accredited?
That's a great question, and it's really it's a classic chicken and the egg scenario, in the sense that there's not a safe harbor currently recognized by any regulator, Department of Labor, Department of Insurance, or otherwise. It's really something that has to evolve over time through the demonstrated success of URAC accredited health plans in the marketplace. So I think it's something that many regulators are interested in doing. We've had lots of meetings with departments of insurance and with the Department of Labor and others about the scope and level of detail that is reviewed by URAC in the accreditation process. And many of them are amazed that it's such a sophisticated review, and are excited about it as something that they can rely on for their comfort. But it's not something that's happened yet, but it is definitely something that many URAC clients are interested in, and I think many regulators are also open to. It's just, I would say, perhaps around the corner on the path we're walking.
Thank you. With that, Robin, I'm going to turn the floor back to you so you can talk about UREX program and how URAC can help with this.
Sure. So this is complicated stuff, right? This is, it's evolving, it's heady. You know, we understand health plans are in the business of health plan operations, and we want to be able to support plans and others who are interested in ensuring their compliance. So again, the federal parity laws are complex, they're expansive, and in some cases they're ambiguous. Again, we've leaned heavily on Kevin for some of the interpretation of regulatory and sub-regulatory guidance. And then the parity rules imposed by the Consolidated Appropriations Act represent, as Kevin said, new obligations for health plans that have not been consistently enforced before. So again, when we think about the need, that's really the driving need today. In terms of the value proposition, the next slide I'm going to share with you is really going to talk about our solutions. And we've got really three unique solutions that we believe will help implement and enforce federal parity law and applicable state laws. This includes opportunities to automate and document the NQTLs. As Kevin has said, it's similar in healthcare. If you didn't document, you didn't do it. So the importance of documentation of your comparability of your NQTLs with mental health, substance use disorder, with medical, surgical benefits in writing and in operation. That's what our tool does to further validate the plan is treating the mental health, substance use disorder coverage requirements consistently with medical surgical care. Parity Manager, I'll get into, accomplishes this and maps the current federal and state parity requirements. So again, these are three, thank you, Lisa. These are three unique tools in what I'll call the URAC Parity Compliance Toolkit. The compliance guide is what it sounds like. It is a guide, and it includes, it summarizes the regulatory and sub-regulatory guidance under MAPIA. It offers practical guidance on how to ensure compliance, and it's for sale currently on UREX online store. So again, if an organization's legal team, compliance team really just wants to get acclimated, that is, we keep it up to date based on the regulatory, sub-regulatory changes that are occurring. Parity Manager, again, is one of our tools in the toolkit. It is a web-based online tool, or I call it a platform, that clients license on an annual basis. Its structure offers the client organization an opportunity to identify and classify the covered benefits, follow a framework. You know, I often say accreditation, and in this case, Parity Manager, which is a software tool, really drives the function of parity compliance. So it's a framework or a map, whatever you want to call it, for quantitative testing of financial requirements for both the NQTLs as well as the QTLs. The organization collects and organizes the data necessary. Again, that documentation need to perform comparability and stringency testing for the NQTLs. And the beauty of the system is it automatically identifies a wide range of per se violations. And like anything in quality improvement, it generates feedback loops and reports and analyses to guide parity compliance. And from my perspective, that drives efficiency and focus within an organization where it is out of compliance with parity, so that once you're in compliance, the system says you're cool over there, but you know what? In this particular benefit, in this particular sector, whether it's inpatient, outpatient, you need to address, you've got inconsistency or lack of parity across medical, surgical, and mental health. And, again, the parity manager, I look at this as it's really meant for an organization to reflect and to look internally. I think about the compliance team, getting this and really taking ownership to really evaluate compliance internally. However, the next step of, I call this the glide path, is our accreditation. The accreditation uses Parity Manager as the tool for accreditation. So you literally fill out the same form, you do the same documentation, but the difference with the accreditation, it's the external validation of your compliance with parity. And that's where organizations feel comfortable. They feel very comfortable with that they are in compliance, and they want to be able to demonstrate their compliance with parity through external validation, and to be able to communicate to all of their stakeholders that they have demonstrated successful completion and successful compliance with parity. I won't go into all of the detail, but it is the first accreditation of standards for health insurers and health benefit administrators to assess MAPIA compliance. That roadmap I keep talking about, it's like a recipe, if you will, and you upload the documentation that you develop in support of the algorithms that have been embedded. And you use the Parity Manager, as I said, to report, to gather that information when making that accreditation decision. And for those of you who are not familiar with URAC, we have both a desktop review where you upload documentation in support of, or as evidence of, compliance with the standard on desktop review. And then we assigned our employed reviewers who go through extreme training, specifically for all programs, this one as well, to ensure that we evaluate your documentation based on each of the standards as part of mental health parity. And then upon appropriate demonstration of completion, we send blinded accreditation reports to our accreditation committee, who on a blinded basis makes the determination whether an organization has earned mental health parity accreditation. So again, glide path, they build upon each other. And this vertical and these various tools in the toolkit were really developed to offer choice to organizations based on where they sit in their compliance efforts.
Robin, thanks so much. And Laura has been chatting in the chat box where you can find all of those. And Deanna is open to having conversations about which of those products is right for our clients.
All right. If you want to go to the next slide, again, functions of Parity Manager. The beauty of it is it really is an intuitive system. We've worked with some programmers who really have helped us take that regulatory and sub-regulatory regulation and put it into a framework that is palatable and that is understood by clients. So it is intuitive, it's streamlined. It creates those frameworks for the financial requirements, as I said, for both the QTLs and the NQTLs. So again, that financial framework with appropriate documentation is there to demonstrate support. It really does implement an innovative approach to collecting and organizing that data necessary to perform the comparability and the stringency testing for the NQTLs. There's an automatic identification of potential violations. And I think the beauty of this particular component of the system is it allows an organization to focus. So if you are in compliance, you don't need to worry about, you are in compliance with these particular issues. What the system does is where you are not demonstrating parity, you actually can focus. So again, it's a series of feedback loops and iterations, which over time you can continue to focus to identify the gaps that you've got in your parity compliance program. Next slide, please. So in terms of the program value, parity is complicated. It is. We all heard healthcare is complicated, and parity is definitely an acquired taste. So this program, with the help of our attorneys and our external partners, have developed this program such that an organization who either uses a parity compliance or parity manager or who seeks accreditation for mental health parity, substance use disorder accreditation through URAC will meet federal and state parity requirements. Our tools are revised to reflect current regulatory and sub-regulatory requirements. And the beauty of the fact that it is an enterprise-wide tool is we understand healthcare and parity is a team sport. So multiple users can upload necessary documentation in parallel. And organizations have the flexibility to identify those end users. Again, if you've got to work on network management and you've got staff, we want to use this platform and framework to encourage collaboration within an enterprise so that the enterprise can be successful in seeking parity. It also, we have found, prepares organizations for market conduct exams as well as RFP requirements. And we did work with a state last year that did use the parity manager to demonstrate compliance with parity to CMS. The whole notion of quality improvement, which is part of URAC's DNA, is embedded in this program through the iterative feedback loops that I talked about, which drives towards parity compliance. And really there is that piece of efficiency, as I talked about, where an organization can focus its efforts on where it is not compliant with parity. Lastly, we've all heard and are working individually, holistically to address health equity. We believe that this tool also will help organizations demonstrate that they not only speak to health equity, but actually follow through in their actions to address, promote, and hardwire health equity. And lastly, what I would say is in terms of communicating to stakeholders, especially for the accreditation, it communicates to stakeholders that an organization is committed to parity compliance, and willing to undertake the effort to meet those requirements as external validation. So I believe I did skip one, I apologize. It updates, you can use the feedback from the system as well to update your payer medical management processes, again, just to ensure that you've got similar processes on both sides of the fence, again, the med-surg versus the mental health parity. So again, it's an opportunity to take a look at the Parity violations and then what you need to do to ensure comparability, stringency across both sides. So I'll leave it there, but wanted to kick it on over to Roger. Roger is a long-standing member of our board. He is an internal medicine physician as well as a psychiatrist and has lots of thoughts on behavioral health, but thought we would give him a couple of moments to talk about how accreditation improves patient treatment and care and URAC's commitment to behavioral health, more importantly. Roger.
Thanks very much, Robin, and welcome everybody. I'm the end of this presentation, and then we'll go to questions and answers. But as Robin mentioned, I'm really very interested in the delivery of improved care to patients. I work on both the medical and the behavioral side. as an internist and a psychiatrist. And one of the biggest problems or challenges that organizations have is that behavioral health tends to be sort of the lost child in the background for patients. And yet it is patients that have comorbid medical and behavioral health problems that cost our system so much. And parity is one of the ways in which this can improve the outcomes for patients, both clinically and economically. Now, this slide shows that there are a variety of areas in which parity has been being discussed and introduced. Certainly, URAC has been a leader in bringing behavioral health into the various kinds of products that it sells as far as accreditation products. But parity now brings it to sort of a next level. I mean, this is really going to be an opportunity. It starts at the health plan level, but it leads to direction for the care delivery systems that are going to then be implementing improved behavioral health for the patients that are seen in the clinical setting. So for a long time, I've been very interested in moving toward a parity of medical and behavioral services. And this is really a beautiful start to that process in the accreditation world, which has significant meaning, certainly as we've seen from the lawsuits that have been awarded against organizations that have not met parity standards. But from my standpoint, more importantly, on behalf of the patients that have comorbid illness that is inadequately treated in our current split system. So I guess I'd just like to say that I'm very pleased to be a member of the Parity Leadership Group and URAC's activities. And I'll close there and I guess open it up to questions for people.
Thanks, Roger. As you can see, as you're chiming in your questions, you can see I've put up here a slide on URAC's ongoing commitment to behavioral health. And Robin, I'm going to ask you to turn your camera back on, and we can talk a little bit about how we started with behavioral health components in our programs more than 20 years ago, really with case management, which is one of our core programs that we do. And we've incorporated into everything. We've incorporated into health plan, we've incorporated into patient-centered medical home. It's not new to us here.
Mm-hmm. Yeah, I would say we do have a great group of leaders here and board members who really take a very proactive and I would say a very Renaissance approach to total person care, and really have even before the Milliman reports came out that demonstrate that, you know, the cost of care of physical med-surg care, you know, increases 2, 3, 10 times if a behavioral health issue is not proactively or effectively managed. And so because of that, we really have had great commitment from our board and from our former, CEO to ensure that we bring in the principles of total person care, again, meaning both the behavioral, the substance use disorder, as well as the med-surg into our programs. And in fact, we've just completed a health plan update, and we included and added quite a few concepts around behavioral health, as well as mental health parity into that particular program update. So again, this is not new. I always say it's in our DNA, and we will continue to go forth as we continue to develop new programs with the same thinking.
So Robin, Peter here is mentioning the patient-centered medical home in there. And I know that's, we've had that program for almost a decade now. We do have it as part of the Venn diagram in there. Can you speak to that a little bit?
Yeah, in fact, I'm not sure. I'm just reading the question now. So we do have primary care medical home, and we just updated that program in, goodness, it was Q4 of 2020. All hands on deck, internal review, and we did continue to strengthen the notion of interdisciplinary care and behavioral health, substance use disorder. And then in addition to that, we've developed some designations that can sit on top of programs so that organizations who elect, right, not mandate, elect to think about patient-centered medical home can think about a substance use disorder designation, for example, an integrated behavioral health designation, for example. So we understand, we want to meet organizations where they are, and knowing change is difficult. Elective designations is an opportunity to add, an area of focus on top of an accreditation, which really helps an organization adapt to, revised thinking and, a framework or a recipe, as I like to say, that really helps them navigate how best to do things efficiently.
Robin, we've also seen it. I'm looking at 2017, which is our telehealth, but we also we released our revised telehealth program in the fall of 2020.
Yep.
So we have it there as well, and recognizing the growth in telebehavioral health services is important here too.
Absolutely. And that was when we updated our telehealth 3.0 accreditation standards in September. Actually, they were released September 2nd of 2020. I remember the date. We, again, included notion of interdisciplinary care, really asking the organization to define the scope, but ensuring that if they did include, anything around med surg, if their scope included behavioral, they have to give equal weight to that. So yes, that was an update as well. Although I think we actually did include that in the 17, the 2.0 version. We just, again, enhanced it as we revise programs, because we're taking a look at what's happening in the market, and we want to make sure that our standards reflect what's happening in the market.
Great. Thank you so much. I'd like to thank our panelists for being here with us today. Roger, Robin, Deanna, and Kevin. Got a lot of R names in there, confusing me for a second there. Thank you all for being here. We've got contact information up here. Laura has chatted in several of our websites. If you need anything, we'll follow up. We'll follow up with a link to the recording. Thank you everyone for joining us. And this officially concludes today's webinar.